Welcome everyone to Know Neuropsychology. We're going to be starting our presentation for today. My name is Yvonne Kwaja-Reddick, and as you all know, that Know Neuropsychology is a didactic series that brings you lectures from experts in the field covering different topics each week. And it was created by trainees and early career neuropsychologists on our board, as well as members of the Know Neuropsychology Committee. And one of our goals is to provide free, high quality didactic content to our audiences. And every lecture is on our website as well as our YouTube channel. So be sure to check it out, subscribe, and like our lectures to get first access to new content. Know Neuropsychology also partners with APPCN to bring you learning and discussion questions that are provided with specific lectures content. And you can access these on our website and through APPCN. These are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted through the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week, and I will be sure to address all the questions for our speakers at the end of the presentation. Now it is my pleasure to introduce Dr. Arias and Dr. Strutt for today's lecture titled Deep Brain Stimulation in Spanish-Speaking Populations, Insights and Overview. Dr. Arias is a bilingual, bicultural assistant professor at the University of Florida. Her clinical and research interests center around the cognitive health trajectories of older adults and cross-cultural neuropsychology as an important way to mitigate health disparities and understand how chronic medical illness interacts with the acute medical events and socioeconomic factors to precipitate cognitive decline. Her research has been funded by the Alzheimer's Association, the National Institute on Aging, and the National Institute of Mental Health. We also have Dr. Adriana Macias-Strutt, who is a bicultural and bilingual board-certified clinical neuropsychologist with a primary appointment in the Department of Neurology and a secondary appointment in the Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine in Houston, Texas. She is a fellow of the Hispanic Neuropsychological Society and the founding director of BCM Cerebro, a Spanish outpatient neuropsychology clinic, and the Spanish Cross-Cultural Neuropsychology Fellowship at Baylor College of Medicine. In 2017, she founded Taquitos de Sesos, an international online didactic program with over 1,200 registered participants from 14 countries with monthly presentations focusing on enhancing practice, research, and patient care via an international and inclusive lens. Dr. Strutt was trained as a lifespan clinician and currently works primarily with adults and older adults. She conducts neuropsychological assessments for bilingual and monolingual Spanish speakers and interpreter-mediated assessments with neurocognitive batteries in over 12 languages. In addition to general outpatient assessment services, she provides pre- and post-surgical evaluations. Dr. Strutt is also a clinical researcher and international educator and conducts lifespan forensic evaluations for civil and criminal matters. And with that, I give you our incredible speakers for today's presentation.
Hi, everybody. Thank you so much for the invitation from Know Neuropsychology. We're very excited to be here today. We feel that we have a lot to cover, and you'll have to pardon us because our schedule did not allow for us to actually practice this presentation together. So we will keep a close eye on the clock to make sure that we get through it. So let me see. Okay.
Can you see my screen?
I can.
Okay.
Yes, if you can go ahead and go to the next slide.
Okay.
So as it was just presented in our short bios, we have no financial conflicts to disclose for this presentation. Next slide. Okay. So here we're just going to go over our objectives for today's talk. We have 4 primary objectives. Via an international lens, we will discuss the prevalence, outcomes, and utilization of deep brain stimulation for the treatment of Parkinson's disease in Spanish-speaking patients. We will identify cultural and linguistic factors that may impact DBS outcomes. We will learn about the Salud model and how it has been used to guide the development and maintenance of pre-surgical neuropsychological clinics for Spanish speakers, both at Baylor and at the University of Florida. Discuss some of the socioeconomic, social, and structural factors that impact access to DBS for Spanish speakers, and identify strategies for improving patient care that is culturally and linguistically appropriate. We know that Know Neuropsychology is a wonderful resource for trainees and early career neuropsychologists, so we will begin this presentation by having Dr. Arias provide a brief introduction to deep brain stimulation and the research that has been conducted to date.
Muchas gracias, doctora. Can you guys hear me okay? Yes. Okay, perfect. And so, I'm not gonna belabor point. Most of us are already probably a little bit advanced in our careers as neuropsychologists, but I'm gonna start with a brief overview. What is deep brain stimulation? And so you think about deep brain stimulation as one of the least invasive procedures, and it's really considered more of a neuromodulation rather than a surgery per se, even though it lives in the realm of surgeries to the central nervous system. And so it involves implanting electrodes to different areas of the brain and connecting those electrodes to a small pulse generator that actually is implanted also in the sort of chest space, if you will, and so the subclavicular space. The deep brain stimulation was actually introduced and approved by the FDA in 1997 for the treatment of Parkinson's disease. And initially, the target for implantation used to be the thalamus, but given the awake nature of the procedure and the feedback that one is able to get right in the surgery at the time of surgery, and then the ability to actually go in and modify some of the settings in the device has actually expanded and supported sort of the intervention in different areas of the brain. And right now, currently, the subthalamic nuclei and the nucleus seems to be the best target of DBS neurostimulation, both for treatment of Parkinson's disease, for the rigidity, the tremors, the akinesia that one can see in this population, but also indirectly for the treatment of some of the dyskinesias that can come secondary to medication related to PD. And so, so even though it was introduced in 1997 by FDA to really treat Parkinson's disease, it has been expanded, and now we use it for essential tremor, for dystonias. There's also a wealth of literature sort of looking into DBS and the use of DBS for the treatment of treatment-resistant depression, as well as obsessive compulsive disorder. And so, like I said earlier, there are a number of targets of intervention. We are predominantly, the research that we are looking into and talking about today is going to focus on the subthalamic nuclei. And it's just because it's been the most effective in terms of treating Parkinson's disease symptoms more holistically. Let's see. So let's go into the next slide. So what do we do? So in addition to the patient population and the cognitive sequelae that we know is hallmark of Parkinson's disease, some of the rigidity, initiation difficulty, processing speed, the tremors, right, that could be quite debilitating. So what is uniquely and what has been uniquely attributed to DBS, the actual procedure? And so the literature is overwhelming, and a quick review, a PubMed search of articles on DBS for English-speaking patients gives like about 308,000 hits. And so there's a robust evidence. And so overwhelmingly, a reduction in verbal fluency has been consistently identified in the literature. Less so, there are reductions in verbal fluency, reductions in verbal memory, as well as visual spatial skills. But again, this seems to be some differences or difficulties sort of synthesizing this literature and really attributing that to the procedure itself or to the pre-existing conditions of the patient population that have been used in different studies. And so just to summarize the literature, so as recently as 2024, I think some of the articles here are from 2024, the impacts on verbal fluency have been isolated to actual verbal fluency. It don't extend to other measures of language. So for example, confrontation naming have not been found to be compromised in patients with DBS or patients who undergo DBS, or found to decrease in patients who undergo DBS. The underlying mechanism by which DBS can impact verbal fluency is less understood, and the overarching consensus among systematic reviews and researchers in the areas is that we need randomized controlled trials, and we need additional literature that actually uses more refined language measures, so that are not time, that is not just confrontation, that includes maybe some more potentially language comprehension and other expressive language sort of tone and rhythm and even output in terms of phonemic output. And so unfortunately, the literature on DBS outcomes or the cognitive sequelae associated with DBS in Spanish-speaking patients is less robust. So I told you earlier that a quick search, a quick PubMed search for DBS in English-speaking populations gave us about 308,000 hits, but not even a quarter of that is seen for DBS in Spanish-speaking patients, and we didn't select only US-based studies. So about maybe like 8,000 if you really think about it. And then when you start looking more at actual not reviews, no, not systematic reviews, the size of the literature available for those of us interested in practicing and serving Spanish-speaking communities is small. So what has been done? So we have a lot of European studies coming from Spain, studies coming from Latin America, for example, Argentina, Chile, and even Brazil, sort of documented an increased variability in terms of cognitive outcomes post-DBS long-term, or at least within the year after the procedure in Spanish-speaking patients, which suggests that maybe the length of a re-evaluation in Spanish-speaking population should be extended beyond the 12-month mark, because there may be some variability that may just be related to normal recovery after a procedure, or maybe even adjustment to a device, right? So, but we do see some effects in verbal fluency that are not extended to phonemic articulation changes. And we also see some minor changes in terms of memory. However, again, there's a need to actually increase the body of literature, because the findings that we are seeing are coming predominantly from monolingual Spanish-speaking countries, and then populations that may not actually experience similar either migration trajectories or potentially some of the cultural and social factors that persons living within the US experience. And so there's been, so in addition to some of the literature being more systematic review related when it comes to DBS in Spanish speaking, a lot of that literature also highlights sort of the disparities that exist and some of the barriers to access and barriers to care. That has been the predominant focus, if you will, of the literature here in the US when it comes to Spanish-speaking populations, rather than truly understanding whether these assumptions about brain development and a target for intervention stand when the language is, when it's in a multilingual brain, or potentially a brain that has gone through migration, through some that is experiencing some social context that may not may impact cognitive functioning. We're focusing on the disparities and the fact of access, which is important in and of itself, but it leaves a wealth of of information to be queried and research to be done, future directions, if you will, for us. And so why are we focusing on Spanish speaking? And I already sort of gave you a little bit on where I was going. So number one, because the depth of the literature is limited. But number two, because we are starting to see more and more of these patients in our clinical practice. I did my internship here at UF a couple of years ago. Not that I'm not gonna age myself, so just a couple of years ago. And so then at that time, Spanish-speaking patients referrals for pre-DBS were coming maybe once every few months, maybe once a quarter, if you will. But now we see them pretty regularly in our clinic. And so we're the overarching landscape and demographic characteristics of the US population is shifting to the point that we are starting to see more of them in our clinical practice. We're also understanding and seeing that the heterogeneity that characterizes the Latino population is also manifested in clinical settings. So for example, some of them are coming in with insurance, some of them are coming in quite privileged positions, so being able to fly across the country to undergo these extensive evaluations or workups for DBS, and others are just community members who may require a ton of assistance from family members and from relying on public insurance to cover some of their care. In addition to the heterogeneity in terms of access to income, in terms of background, cultural background, we also see disproportionately Hispanic Latinos being affected by things like food insecurity or limited English speaking within the household, lower literacy relative to some of their counterparts, and all of these things, again, not to create a generalizable picture of Latinos, but these are also things that us as clinicians are having to sort of delve into and sort of characterize and integrate in our conceptualization and even in our decision making about protocols. Okay, so again, this has healthcare implications. What I spoke with you about the heterogeneity and the differences, and then some of the more the intersection of some of those social vulnerabilities and systemic factors. And so we have some of our patients coming in, if they're Spanish speaking, they may be more likely to show some co-occurring conditions, particularly vascular, which may impact their brain integrity and therefore can impact prognosis and long-term outcomes. There are also structural barriers, so challenges when receiving care. And so, for example, we know that Hispanics overwhelmingly encounter barriers when communicating with providers, and that they rely on their caregivers and family members to actually engage in some of this work. So again, this has implications for us in terms of, you know, when you're providing feedback, if a family member is not there, or if a family member is not available on the day you're trying to schedule that appointment, that may be a potential barrier for that patient. And then there's also social and cultural aspects, right? So there may be a more collective approach to problem solving, one that involves multiple players, requires maybe scheduling of multiple people that, you know, that can represent a barrier for us, or potentially even a protective factor. And so I'm going to tell you a little bit about the numbers in Florida. And so currently we have about 13% of the population in Florida is Spanish, Hispanoparlante, no, Spanish speaker. And the map can, like Dr. Stroh says, the map says it all. I don't have to go into belabor the point. So Florida's Spanish-speaking population is estimated to be over 4 million. And it's kind of comprises at least a quarter of the state's population. We do have at UF Health, we actually, relative to Gainesville, Florida, which is our primary hub for provision of movement disorders and neurological services. Here in Florida, we have about 9%, 10% of our population, with approximately 7% actually being referred to neuropsychological services at UF. And again, we have a quite diverse group of people in terms of age ranges, but the clinics that we provide movement disorders, Parkinson's disease, is actually predominantly older adults, and generally like 55 plus or so.
Okay,
doctora.
great. I see it. Sorry, I think there's a little bit of a lag. So a similar demographic in Texas, where the landscape in terms of the Hispanic community. In 2022, Hispanics were the largest ethnic minority group in Harris County, with 2.1 million Hispanics. So Baylor College of Medicine is located in Harris County, which is the largest county in the state. And currently, Hispanics make up about 44% of the county's population. So as you can see, based on these statistics, both Dr. Arias and I, who are bilingual, understanding the diversity and the needs of the community is what has brought us together to work in addressing this health disparity. Next slide. So I think with our experience as clinicians, we can see the value in providing patient-centered care. And this slide gives you a little bit of a flavor from both directions, right? Understanding how the patients and the family, their view versus the providers or the institution, and then realizing that some of these factors can be similar. For example, maybe limited resources. That can be something that both the patient and the provider will share. If you are not a Spanish-speaking provider, then you will require an interpreter to assist with that, to provide interpreter-mediated assessments. It could be that the institution has limited funding for those type of services or for the batteries and protocols that you will need as an examiner. And I think some of the important things to consider are the cultural beliefs and the attitudes about disease and aging, which we know can be, that those can vary across different cultures. And I think one of the most important things that I would like you to consider is as we go through this slide and you see these little boxes of factors, is that here, we don't have to say that these are the concerns only for our Spanish-speaking community. These are the concerns of every patient that we see. And so, we can definitely appreciate some of the similarities coming from both of these worldviews, both the providers and the patients. But I think we can also appreciate the differences. And so meeting our patient where they are, understanding their world of view, respecting that, and understanding what's of value to them. Maybe for us, things like the etiology and I don't know, norms, measures, all those things obviously are of high value to us because that's what we need to do our work. But maybe for our patient, the etiology doesn't matter, or the etiology is too hard for them to understand or appreciate. And what matters to them is how their disease will impact their day-to-day. Will this allow them to return to work? Can the DBS maybe give them back some of their quality of life? And so these are very important things that, I think require some time to sort of sit back and reflect on them, so that you understand how you view these yourself as a provider, and then how the patient and the family understands them as well. Next slide. So in understanding this is work that I did with Dr. Beatriz McDonald, who everybody knows her as Tish, so Dr. Tish McDonald. We were trying to understand the day-to-day services that we provided, both as clinicians, as educators, and then trying to figure out how we could maybe come up with a framework that would help us develop our programs a little bit better. So this is just consider this slide and the next slide as a theory of, a reference slide that will cover some of the theory and existing frameworks. We did do our research and look to see what was available in the literature. But based on our practices, we realized that some of these models were not complete and that they didn't give us really a complete framework to help us understand what we needed to do to make our own improvements, and then how to move these clinical services outside of our institution, and not just provide them to students, but also provide this information to colleagues. Next slide. And so we did consider, the neuropsychological literature, foundation articles by Dr. Rivera Mint, by Sue et al. And then we did some future work with trying to come up with protocols that could be used with primarily Spanish-speaking adults. And so if you're interested in this information, please look at the article that's on the slide. This provides you with a battery for assessing adults and older adults, not just as a pre-surgical evaluation, but also an evaluation that you can utilize in different settings. And we talk about normative data and what is available for folks who are Spanish speaking from different countries of origin. So consider these couple of slides just as a reference that you can head back to. Next slide. And so within our own clinical experiences, Dr. McDonald working with in pediatric settings with children and adolescents, and then myself mostly with adults and older adults, we were able to put together this model that you see here, referred to as the Salud Strutt-McDonald Equitable Healthcare Model, with the goal of increasing, the healthcare equity across the different interventions that we provide as neuropsychologists. So looking at research, clinical services, education and training, consultation, clinical application, integration, development, and quality improvement. And so this is a quite complicated model that has a lot of different elements to it. Next slide. And for the purposes of today's talk, we're just going to focus on the clinical services, the clinical application and integration, and then consultation and collaboration. So when you do have the opportunity to go back to the larger picture, you can see that these three elements of the model are what Dr. Arias and I have focused on. And so I have known Dr. Arias for several years now. And what I'm going to share with you today is work that I started doing as an intern. I will be aging myself. So 20 years ago as an intern at Baylor College of Medicine, I was able to come on board and do some work with the existing pre-surgical neuropsychological clinic that was there. And so that was a wonderful platform for me to be able to integrate services for Spanish speakers. And those services have now, 20 years later, developed not only just for Spanish speakers, but through our ECHOS clinic that's directed by Dr. Stephen McCauley, looking at interpreter-mediated services so that we can, also provide additional services. Next slide. So a little bit about the Parkinson's Disease and Movement Disorders Center at Baylor. We are a center of excellence with a large group, as you can see here, that includes neurologists and neurosurgeons, neuropsychologists. I know some other institutions also include additional members in their multidisciplinary team. Dr. Arias will cover that here in a bit. But what we have been able to do in the past 20 years is establish a service for our Spanish-speaking community with a Spanish battery, with normative data sets. Currently, these are some of the things that we are working on, which is the health literacy component, so that our Spanish speakers actually have information that is shared with them in their language. We are opening up our research line in collaboration with the University of Florida and Dr. Arias, and a university in Guatemala to look at some of the services that we've been able to provide, consider quality improvement, and also to look at pre-post surgical outcomes. And so these collaborations have also led to the development of a new battery that is in the works, so that we can address other things in addition to cognition, which we know is very important to the neuropsychologist, but we want to try to take a holistic approach. And they'll also understand why some of the folks that come in for their neuropsychological assessment actually don't follow through with DBS. And so to better understand why is that happening, who are these folks, how can we as providers try to make this service more accessible to them, and so also work with our institutions to address some of these barriers. Next slide. So what we're going to do now is focus on the new up-and-coming clinic of Dr. Arias. I know that she's been in practice now for about a year or so, but she's going to walk you through a step-by-step in understanding her team, how the model was utilized in order to establish the services that she has, and then her vision for future services and understanding how this is all put together in hopes that you can return to your institution with some of this information and begin a service of your own.
Yeah, gracias, doctora. So in terms of understanding, so I wanted to lay the foundation. So two things want to clarify. Number one, it is true that we have several models. Dr. Fuji's model, it provides a very particular, like, overarching kind of guide for those of us interested in multilingual kind of in the work in this area of neuropsychology, cross-cultural, multicultural, multilingual. But I think that what I found helpful about the Salud model is that it provides a lot of structure and it gives me a lot of guidance about the multiple players that may be playing a role. And so it actually inspired me not to leave any stone unturned. So how can my service be predominantly and foremost so helpful to the patient? And what are some of the elements that I must be aware of in order to achieve this, right? And these are things that we're trained all the time to do and to think about. But then if you think about, like, what about collaborations, right? And how do I leverage existing resources? And what about training for different levels for, graduate students, interns, postdoctoral level trainees? But what about training for other colleagues from other specialties where, their awareness about how cultural language and other factors may be interplaying to impact the presentation of the patient and even their decision to move forward with our team with it for a procedure, right? And so this is what was very unique to me for the Salud model. And I'm gonna call out Dr. Strode and Dr. McDonald. I want you guys to publish this. I need to see this publication because I want to cite you everywhere. And so let me see. So here at UF, the resources and the infrastructure was already in place. And I was very lucky. And some of you in other places of the country may not be. I came in with Dr. Michael Oken and Dr. Kelly Foote. It was a service that was started in 2019. And the service integrated from the beginning Dr. Don Bowers. And it was interdisciplinary and it was extremely collaborative to the point where these partners are actually working together, not just seeing their patients, but also writing these grants together, presenting conferences together, and publishing together. And so what started in 2002 as like a couple of like maybe 10, 12 people has grown into its own center with both private foundation money, but also RO1s. And it is a center of excellence and has been awarded these by the Parkinson's Foundation Centers, but also by the Alzheimer's Disease Association, the more ADRD plus kind of grants. And so we have a team that includes neurologists and neurosurgeons, psychologists and psychiatrists, rehabilitation therapists, advanced practice providers, clinical nursing staff, research staff, and counseling therapies. So everybody coming in through the movement disorders at UF that is under consideration for DBS is going to meet with some of these providers, or at least receive some kind of consultation with all of these providers. So not only are does the patient gets evaluated, discussed as a group in our weekly consensus conferences, but also the contribution of each providers is actually given to the whole group. And so this is particularly, again, I want to highlight how privileged I was already coming into this team. And so some of you may have a heavier lift. And so let's see. So currently, the enterprise that started as 12 providers has currently over 100, and these are just a few of them that are included at the Fixel Institute. And the patients come in are scheduled for a 2-day kind of pre-DBS workup, and they coming in that morning, let's say on day 1, and they see psychiatry, they see neuropsychology, then they're taking a break, then they meet with their surgeons. They also also meet with the dietitian to discuss any concerns. And then on day 2, they return to meet with a few other specialties. After these, all elements of this pre-DBS workup are completed, the patients are discussed, and a decision is made from the point of view of the team, whether this is a good candidate for this procedure and whether it's going to be unilateral, bilateral, and bilateral, unilateral procedure, and why, right? And then this information is then presented to the patient, presented to the family members, for them to make a decision about whether they would like to proceed or not. You can see here that even though, and this has been the bulk of the work and the lift that I have had to do here at UF. So the idea was, well, we brought a surgeon and a neurologist, not really a surgeon, a neurologist that's Spanish speaking, and we brought a neuropsychologist that's Spanish speaking, and then we brought a psychiatrist that's Spanish speaker. So our work is done. We're doing better than the rest of the country, which is true. We're doing better than many other places in the country. But the reality is that at many places in this model, there could be opportunities for cultural adaptation, for linguistic adaptation. So what materials are we sending these families to at home? Who's registering them? Who's enrolling them? Who is explaining to them the financial aspects of this procedure that none of these specialties actually talks about and covers? And these are some of the elements that have emerged in my conversations with Spanish-speaking populations, and also in the conversations with other Spanish-speaking providers who are like, Francesca, did the patient ask you this? And I was like, yeah. Is nobody able to, oh, we don't have a Spanish-speaking provider doing that or X, right? And so a little bit of acknowledging for sure what this team has done and their efforts and the continued desire to improve, but also acknowledging where there are clear rooms for improvement, and where, if we're thinking about equitable care, we will never talk to a patient about their eligibility or candidacy for a procedure without really talking to them about the finances and what may this look like in terms of how many weeks are you going to take off from work, or if you're not working, how many weeks are you going to need a caregiver for, and is this an option? And I think that those are the little tweaks where my knowledge and my understanding of the culture has come up to play. Additionally, with recommendations, right? So do we do cognitive rehabilitation? For how long and in what language? And it will depend on what areas this patient is wanting to improve communicating, etc. Right? And so again, this is where the cross-cultural elements have come to play for me, and the battles that I have had to, I shouldn't call them battles, but the advocacy work I've had to do. So I'm not going to make that. We decided we weren't going to make this talk a discussion about patients and protocols, etc. But we can answer those questions if they do emerge. But what does my protocol look like? If you really think about what I talked earlier about what we have seen in Parkinson's disease, what's the presentation, the hallmark features of the condition, and then we're thinking about, well, eligibility for DBS surgery, and then long-term prognostic outcomes, and even monitoring. So I do a performance validity instrument, and that will vary depending on the age and level of education of the patient, and whether they're predominant or primary Spanish speakers or they're pretty balanced bilinguals. I do pre-morbid estimates in reading abilities. I do intellectual functioning. And again, we're talking about maybe a 4 subtest, maybe a 2 subtest kind of perceptual reasoning combined with vocabulary, and then attention, processing speed, learning, and memory. And when it comes to language, I go a little bit deeper, right? I assess not only confrontation and speed and fluency, but we also do some of the TIVIT, so vocabulary identification based on the definition of a word, or some of those sentence comprehensions, if I think that this may be clouding our picture, and there may be some questions related to pre-existing learning difficulties that will then cloud our ability to make recommendations about candidacy, right? Then I do visual perceptual skills, executive function, mood, and acculturation. And again, this is just embedded in everything else that we talk about. We assess during a very thorough clinical interview, we're assessing sleep quality, diet, we're assessing other factors that may impact the day-to-day life of persons living with PD, some of the autonomic symptoms that we do tend to do a little bit more during our clinical interview. And I wanted to say that at every level of this model or our service, we are integrating trainees from graduate students actually not providing care, but certainly observing the clinical interview, observing either psychometry or myself doing a testing session, or postdocs or interns sort of engaging in different aspects. And it's a very, I follow a lot the model of scaffolding. We start with reading about the cases, understanding the protocol, then trainees sort of move gradually, depending on where they are developmentally, move into more patient contact, either via the interview or the feedback session, until eventually they're moved into report writing, conceptualization, and even maybe doing testing themselves. So again, it's a very developmental model that we follow. And so what do we have in terms so far? So I did start my clinic back in the summer of 2023. And so far our referrals for Spanish speakers are about 20 to 22 patients. Like I said earlier, the majority of them are more on the older adult side. We do have some patients who are relatively younger. We do have both national as well as international a patient population. So we've evaluated people coming in for second opinions from Colombia, Argentina, Puerto Rico, people who are actually coming in within the US sort of locally, or even coming from up north seeking maybe, some of the snowbirds who are actually seeking to connect with us here in Florida because they're transitioning to more long-term living here in Florida. The majority of our patient population is male, and this is consistent with the literature for Parkinson's disease and the disparities that have been reported for the English-speaking population, but also in the Spanish-speaking population, whereas males seem to be receiving DBS more in these types of intervention more than female, even after adjusting for some of the base rates of PD in these patients' populations. And so then we also have most of them self-identified as white, and I consider relatively educated, because, the majority of my patients who are not PD patients tend to be lower, probably like a 10th grade education. But here we see at least a high school degree in this population. And Doctora, I think I sped through that. Thank
Yes,
you.
that was
Oh, sorry.
really fast. So we wanted to make sure that we had a little bit of time for questions. I know that it was a lot of information, but the few minutes that we do have, if anybody has any questions, we would love to hear from you.
I'm gonna stop sharing, unless, yeah.
You can keep
Okay.
sharing, that's okay.
Oh, okay,
Yeah.
got it.
Thank you so much for this incredible presentation and for getting through all of it. I think that what we're seeing is such a comprehensive, detail-oriented, culturally sensitive model that is just looking at the entire person, at the entire patient and their family systems and culture. And it is so incredible to see how all of those pieces are being considered. I know that, I'm very early in my training as well, but just the focus a couple of years ago just being so much on what's going on medically, but it's so important, as you all are highlighting, especially with multilingual patients, understanding language, understanding culture, and how that can potentially impact their functioning. Now, some questions that came up were around testing, and wondering if you could answer some of those. In terms of a performance validity, what types of measures do you typically use? Is that something that, yeah, if you could just start with by speaking to that.
So I can take that. Yeah, go
Yeah,
ahead.
go ahead.
Yeah, so it depends, right? And so Dr. Stroh has provided norms for a ton of the tests that I use in my work through her earlier work with PD, some of the DRS protocols like that we use in for DBS for pre-DBS workup. Some of those norms include Dr. Stroh's norms. So I do things like the dot counting tests. I do things like force choice, embedded for choice a recognition test. And I also do the time depending on the population and with some adjustment, very interpreting it very qualitatively and depending really on the age of education. But if you will, I think my go-to are tend to be the dot counting test, RDS, and the some of the those embedded in list learning tasks. Doctor, I don't know if you have other things that you consider.
No, actually, for the RPD patients, I am going to say that we don't use PBTs. We do have RDS, which is part of the embedded. And right now, for research purposes, we are running other embedded measures, but these we have not published on yet. So we are working on that.
Thank you so much for those answers. It's definitely nice to hear that there are some updated norms that are available that you're able to use for these patient populations, of course. Also related to the testing, you had mentioned that you're going a little bit more in depth regarding language. We've heard that there's some practitioners who will do both tests if the patient is bilingual in English and Spanish. Block testing models where they'll do all English first and Spanish second, or vice versa. How do you approach that in your practice for the patients that you're seeing and for the reasons that they're being evaluated?
So we do implement the Language Dominance Index. It is a publication that is led by Paola Suarez out of UCLA. And that Language Dominance Index looks at verbal fluency in both English and Spanish. And that helps us, that's one of the objective measurement that we use in helping us determine the language that is best for the patient to be tested in. And so if, the patient ends up being a balanced bilingual, meaning that they're able to, speak and interact, they both have expressive and receptive language abilities, and it seems to be equal in both languages, then we will consider some block testing to make sure that we are truly assessing the cognitive domains that we want to get at, and that their performance is not being impacted by mastery of the language that we're using. And so with that and levels of acculturation, which if you are familiar with some of those measures, once you start to look at the questions that are being asked of the patient, those questions are really focused on language abilities or language use. Versus any other sociodemographic. And so we try to implement some of those pieces in better understanding the language mastery of the patient.
Yeah,
Amazing.
same
Thank you.
thing here. I routinely use Dr. Suarez. My trainees all read that paper. And so we routinely use that metric to sort of guide some of the inclusion of more language-based measures. But I do tend to be, even if they report some balance bilingualism, I do at least one or two tests in both languages, because it is nice to it's not, because we don't know, there's not a ton of literature on them. It wouldn't be nice to quantify what they look at baseline to see if maybe you may be catching some of the decrements in the second language or the first language, as opposed to across the board generalizable. But I do want to reiterate, if you saw the blocks in day 1 and day 2, neuropsych is smack right in between, and we don't have a ton of time. And so we are talking about quick and dirty measures. So I'm talking about the batería 3, the book of Muñoz, identificación de letras y palabras, no, very, very selected tests, just to say that we have looked into that and sort of established some sort of baseline.
Very nice. Thank you so much.
Yeah, I would say that it's important to maybe create, like what we call at Baylor our language packet, to create a language packet that you use across different patients, and, give yourself some time so that you can understand, the psychometric properties of those measures with the population that you serve. Looking at Dr. Arias, demographics of the patients that she has seen so far, I would say that my sample is very different. So we have folks with no formal education and some folks that have early onset Parkinson's disease. And so if we were to look at that, just age and education, those variables are very different from her sample in Florida. And so depending on where you are and the community that you are in, you have to really understand the measures and, what those normative data, what that's going to look like and what it actually means clinically. So it takes a little bit of practice.
Very good insights. Thank you so much, Dr. Arias and Dr. Strutt, for an amazing talk. And we are so grateful to have you here at No Neuropsychology. We hope you have a great rest of your day.
Thank you. Thank you so much for the invitation. You as well.
Yes, thank you.